Okay, welcome to take two of this instalment of Block Party. After, unfortunately, I forgot to press the record button during the actual session. So this session is going to be talking about the lower limb plan A blocks, which I'll come on to outline in a second. Unfortunately, it looks like it's going to be a while until we can gather in groups in a small room and huddle around ultrasound machines to scan each other and get some live kind of hands-on practice. So hopefully this is a reasonably useful substitute in the meantime. I hope you find it useful, and so thanks for signing on and giving it a go. First thing, if you don't mind, it would be really helpful if you could just scan this QR code or go to that address and spend 30 seconds just filling out a quick Google form survey. We'll do one now and then one at the end of the teaching in 25 minutes time-ish. And it'll just be really useful for us to collect some information. So I'll just give you a second to maybe pause the video and do that. And then carrying on. So this is a table of all the Plan A blocks. So the middle column there are the Plan A, or also known as basic blocks, which essentially, if you haven't heard about it already, the Plan A blocks it all came from a big editorial that was published a few months ago, which described that they think the future of regional anaesthesia is in these 7 core blocks, or they proposed these 7 core blocks. It's open to kind of debate and might change, but they proposed these 7 core blocks that they think every anaesthetist should be able to perform, especially as we're kind of senior trainees about to CCT. We should be aiming to be able to perform all these 7 blocks. And then the Plan B, C, D blocks, as they call them, or the more advanced blocks in the right-hand column, can be the domain of the regional enthusiasts who might be able to perform these slightly more kind of weird and wonderful advanced blocks, but that everyone should be competent enough to do these 7. So a couple of months ago, we had a session on the upper limb blocks when we were allowed to gather in rooms and scan each other. Today, we're going to be covering the lower limb blocks. So that's going to be the femoral nerve block, adductor canal block, and popliteal sciatic block. I'll also mention the Fasciariaca block, and we'll again also mention the lateral cutaneous nerve of the thigh, just because I think that goes together with femoral nerve and Fasciariaca. And then in about a month's time, hopefully mid to late June, we'll have another session on the trunk blocks. So that'll be these 2, the erector spinae plane blocks and rectus sheath blocks. I always find it useful to have a picture or two like this saved on my phone or an app, just as a reminder. I think it's impossible to remember the exact boundaries, although these boundaries of nerve distributions are obviously vary from person to person and aren't precise. Having this map of the kind of cutaneous distribution and osseous distribution of the sensory nerves, I think, is really useful, just to remind yourself before you're doing any blocks, or to help you decide what kind of block might be needed for what kind of surgery. So first of all, we'll talk about the femoral nerve block, which might be used to provide analgesia for femoral or knee surgery. Could be used as the sole anaesthetic for skin graft or muscle biopsy. And it could be used to provide complete anaesthesia for knee or lower limb surgery, but would have to be combined with sciatic and or obturator nerve blocks as well. Technique would include having the patient lying supine with their leg slightly abducted. We're going to want to use the high frequency linear probe. The depth is going to be only 2 or 3 centimeters probably. Recommends here to use a 100mm needle. I think that's probably a bit much for a femoral nerve block. You probably won't need that length, so maybe an 80mm block needle might be more appropriate. We'll talk about an in-plane approach, and we'll talk about the different kind of volumes of local that you might need. But for a direct femoral nerve block, obviously a bit different to a fascia iliaca block, but for a direct femoral nerve block, 10 to 20 mils should be enough to cover the nerve. This is the kind of setup that you're going to want. So ideally everything in a straight line with you over here, probably a bit further around this way compared to where this person is, standing over here, needle, ultrasound probe, and machine over here. So everything's in a nice ergonomic position. I think the easiest way to get your initial view, at least, is to just plonk the probe on right in the groin crease here, which this person has, and you can just slide medially and laterally in that crease and find your landmarks. So when you put the probe in that crease of the groin, you're going to hopefully end up with a picture something like this, where you will have, just to orientate ourselves to the landmarks, we'll have the femoral artery, the femoral vein off to the side there, Fasciariaca here, which comes over the top of the iliopsoas muscle, over the top of the femoral nerve, then dives down under the vessels. You hopefully can see this kind of flat triangular kind of object here is the femoral nerve. So I've highlighted that there. And then that's the iliopsoas muscle underneath. Just as a point for all these pictures and videos, I block everything with my right hand, so I always like to have everything have the needle coming in from the right side of the screen. I just find that works better in my brain somehow. So all these pictures will be blocking in from the right side. It's usually lateral on the right side and medial on the left side. It certainly is in this case. The other thing to point out on this picture would be the fascia lata, which would be the first of the two pops that you'd feel if you're using the two pop landmark technique. It's the first of the two fascial planes that you go through. So it's probably this line here. There are a few lines up here that gets a bit confusing, but probably that line. But essentially, if you're doing an ultrasound guided femoral nerve or fasciariaca block, it's irrelevant really. You want to know where the fasciariaca is, and obviously mainly where the femoral nerve is. So to block that, bring the needle in from the right, go through the fasciariaca, just under the fasciariaca, close to the nerve, but obviously not on the nerve itself, and surround it with local like that. So moving on to mention the Fasciariaca block, which isn't a plan A block as such, as we've seen, but is commonly used obviously to provide analgesia for neck of femur fracture surgery. This picture shows essentially this, similar to the picture for the femoral nerve block, but the probe has been shifted over slightly laterally. So the femoral nerve over here and the femoral artery over here have been shifted over to the left side of the screen. And you can see this nice long fascial plane, the fasciariaca, extending out to the right of the screen. Theory being that you would bring the needle in from the right there into the fascial plane, deposit a large volume of local anaesthetic, aiming for spread over to the femoral nerve, and possibly proximally up the fascial plane up towards the lumbar plexus. So the innervation of the hip joint comes from several different nerves: the femoral nerve and the obturator nerve, which are both branches of the lumbar plexus, and the superior gluteal nerve and the nerve quadratus femoris, which are both branches of the sacral plexus. There's also to think about here is the innervation of the skin of the upper lateral thigh, which is useful to cover for any incision there, such as a DHS procedure, for example. And that's innervated by the lateral cutaneous nerve of the thigh, which is also a branch of the lumbar plexus. So the theory here for the Fasciariaca block is that a high enough volume of local anaesthetic in this plane might spread a bit proximally up towards the lumbar plexus and block the femoral nerve, the obturator nerve, and the lateral cutaneous nerve of the thigh all in one. You're still not going to cover all the innervation to the hip joint, because there are still those branches of the sacral plexus which you're not going to get with this block. I think having spoken to experienced regional consultants, and probably the reason why this isn't a plan A block is that I think is probably a theoretical thing rather than something that really happens. And the block of the obturator nerve and lateral cutaneous nerve of the thigh through doing a Fasciariaca block are extremely unreliable and, in my experience, quite rare. So their argument is actually, why, if you can see a big juicy nerve here, that's the femoral nerve, that's going to give you a decent proportion of analgesia for the hip joint. Why not actually go and block that nerve properly and get a good, reliable femoral nerve block, rather than putting lots of local over here and hoping that you get spread over here, as well as this possible proximal spread to the other branches, which probably won't happen. So what I do is probably a bit of a hybrid of the two, and I kind of come in maybe around here somewhere in the fascial plane, start with a little bit of a Fasciariaca block, but open up the plane with the local and move further towards the femoral nerve block, and probably end up doing more of a direct femoral nerve block. It's still the same plane as a Fasciariaca block in the Fasciariaca itself. So you still, if you put a large volume of local anaesthetic, possibly going to get some of that proximal spread up towards the obturator and lateral cutaneous nerve of the thigh. But at least you know that you're getting a good, reliable femoral nerve block. The other thing I would do, if I needed to cover the skin of the upper lateral thigh for a DHS, for example, I'd do a separate lateral cutaneous nerve of the thigh block, which we'll come on to next. So talking about the lateral cutaneous nerve, how to find it, I'd go from my view of the femoral nerve here, would have just done my femoral nerve block, and then literally staying in the groin crease, like I was saying, slide over laterally, coming over sartorius muscle here, and then you'll find above the kind of lateral edge of sartorius, if you look around here, you begin to find, to see something that looks like it might be a bit of a nerve, and then it's dividing into 2 or 3 or 4 or 5 little smaller nerves as it spreads out to supply sensation to the skin. So we just go back to the start of that again. You slide laterally over sartorius muscle. Just going to pause there. Over the kind of lateral end of sartorius muscle, you have what they call this fat-filled triangle. You can imagine that's a bit of a triangle. And supposedly the lateral cutaneous nerve is always in that, or should be in that triangle somewhere. I think on a still image, it's quite hard to identify, but if you scan up and down a little bit, hopefully it becomes a bit more obvious. So if you focus around here, as the video continues, I'm just then scanning down the leg a little bit, and it starts to become a bit more obvious, I think, I hope. And then it starts to divide into a few different bits. So I'd then scan back up to where it was before it started dividing and block it there. So this is a still image of the same leg with the nerve up here somewhere on top of sartorius there. So it's normally just above the kind of lateral border of sartorius in this little triangle bit. And then I bring the needle in from the right side and put some local around that nerve. And you'd only need a few mils, maximum maybe 5 mils, and you would be plenty for that because it's such a small nerve. Again, a different leg, just showing the same thing. So it's sartorius muscle here, lateral border of sartorius, and it's got here, there's quite kind of flat, fat-filled triangle. I think hopefully you can see there's something in there. Again, on a still image, it's not, you know, you couldn't be sure, but if you scan up and down a bit, you'd get an idea, hopefully, that there was something there. And then a bit further down the leg, it's divided again. It shows this fat-filled triangle quite nicely, this picture. And the nerve is divided into a few different bits there, as you can see. Okay, so on to the next one, next plan A block, which is the adductor canal block. Indications for this would be analgesia for knee surgery, hopefully some motor sparing analgesia, surgery to the medial ankle and medial calf and foot. Technique would be, again, having the patient supine, the leg slightly abducted and externally rotated, just to give you access to the inner thigh. Again, you're probably going to be using the linear probe. It would have to be quite a big thigh with deep structures to need the curvilinear probe. Again, probably an 80mm needle. Again, we'll talk about an in-plane approach and different volumes of local depending on what you're trying to achieve, essentially. But for a typical adductor canal block, you're probably looking at 15 to 20 mils to reliably get the saphenous and hopefully nerve to vastus medialis, which we'll talk about in a second as well. So that would be the setup. Again, everything in a nice ergonomic straight line. So with you standing or sitting over here, needle probe and ultrasound machine over there. It's not particularly abducted or externally rotated, that leg, it seems, but it gives you the idea anyway. So the main thing I struggled with for a while with adductor canal blocks was finding the right level to do the block. I think it's relatively simple to plonk the probe on the middle of the thigh and eventually find this kind of view where you found the femoral artery and the femoral vein underneath, sartorius muscle on top. I spoke to one of the consultants who does a lot of these blocks for knee procedures and knee replacements, and discussed where he thinks the best level to do the block is, because there's various different opinions in the literature and things, whether you could do a high adductor canal, mid adductor canal, low adductor canal, whether you should actually do a femoral triangle block, and all these different kind of ideas of what would be best. He explained that really there are three nerves or groups of nerves that supply sensory innervation to the knee. One being the saphenous nerve, which is kind of the main target of this block that we're definitely going to want to get. The other being the nerve to vastus medialis, which comes off the femoral nerve up in the groin somewhere, supplies motor function to vastus medialis muscle, but then goes on to supply some sensory innervation into the knee. And then the third being the popliteal plexus, which is a plexus of nerves kind of behind the knee, essentially. Now, he explained you can't block all three of those in one. He said the surgeon can block, can do a pretty good job of blocking the popliteal plexus behind the knee, and that's easy enough for them. So we might as well try and target the other two nerves. So he said the most reliable position where you can get the saphenous and the nerve to vastus medialis is going to be quite high up the thigh, actually, right at the top of the adductor canal, or even you might say at the apex of the femoral triangle. It's kind of where the femoral triangle becomes the adductor canal. Obviously, if we're blocking the nerve to vastus medialis, you've got to accept that you're going to get a little bit of quadriceps weakness, just because you're blocking the motor supply to that one muscle of the quadriceps. But you're not going to get a complete quadriceps paralysis, which you're risking if you do a higher kind of femoral nerve block. So we want to find where the femoral triangle, the apex of the femoral triangle, where the femoral triangle kind of becomes the adductor canal. And the landmark for that is where the medial border of the sartorius, which is here. So it's just off the screen. This will be a video which will show it. But just to try to explain it first, the medial border of sartorius, where that lines up with the medial border of adductor longus. Now this is adductor longus here. And then you kind of get a bit of an idea of a fascial plane, bit of a line coming down here. And that's the division between adductor longus on this side and adductor magnus on this side. So ideally, the apex of the femoral triangle or beginning of adductor canal is where the medial border of sartorius lines up with that division of the adductor muscles. So if we play this video, I'm basically scanning up and down the leg. So I'll slide over medially just to focus over these muscles. Scanning up and down the leg. Here you can see big adductor longus. As you go higher up the leg, the adductor longus gets bigger. And then adductor magnus is over here. And the border between the two is this kind of blurry line down here. And the medial border of sartorius is way over here. So they're definitely not lined up. So I've gone too high. So if I then come down a bit lower, they're just about lined up about there. And then if I carry on going even lower, adductor longus gets smaller and smaller, adductor magnus gets bigger and bigger, and I've gone too far. So then I'll come back up the leg, to where they line up again, then just slide over laterally, and that would be the position where I do the block. So this is a still image, basically showing the same thing. So sartorius muscle on top. We'll just orientate ourselves, femoral artery there, femoral vein underneath. I think this is probably the saphenous nerve here. It's not always that easy to see, but I think in this case you can see it quite well. And then sartorius muscle on top, adductor longus that side, like we were saying, and vastus medialis on this side. Now to block that nerve, the saphenous nerve, so I've highlighted the saphenous nerve there, not the nerve to vastus medialis, because the nerve to vastus medialis is not always obvious, not easy to see. Maybe you can see it somewhere here, I'm not sure, but I've highlighted what I can see for sure. But the nerve to vastus medialis will be, the theory is that it should be in the adductor canal somewhere at that level with the saphenous nerve. Now it'd be tempting to bring the needle in down along this fascial plane, thinking that you're going to cause less muscle trauma, and it'll be it's a nice route to come in to the adductor canal. But I think there's a possibility that the nerve to vastus medialis particularly might be in that fascial plane somewhere as it's coming out of the adductor canal to supply vastus medialis. So you maybe risk traumatizing that nerve if you come along the fascial plane. So best to probably avoid that and come through the muscle, just pop into the adductor canal and fill that space with local. It's another picture, just a nice illustration of the adductor canal in a different leg. again, shows, maybe illustrates here that in this fascial plane where you tempted, like I was saying, you're tempted to bring the needle, that maybe that little structure there could be a nerve. That could be nerve to vastus medialis. It might be a small vessel. So again, probably worth avoiding that plane and coming in either underneath or above through the muscle. And hopefully you've noticed this wouldn't be the place to do the block, because the medial border of sartorius, which will be over here somewhere, is definitely not lined up with the border between adductor longus and adductor magnus, which is be this line down here. So this is too low. You'd have to scan probably a good 5 centimeters or so further up the leg until they lined up. Just highlighting the saphenous nerve again. Okay, on to the third plan A block, so the popliteal sciatic block. Indications would be foot and ankle surgery with or without a saphenous nerve block, depending on the distribution and extent of the surgery. Technique, the main things to think about here are the position. So lots of different options. Could have the patient supine with their leg bent up, essentially, their hip and knee flexed, having to kind of dig in behind their leg from underneath, which I find quite difficult. I find your arm gets quite tired and it's difficult to hold it really still and steady. So I prefer having the patient lateral, rolled towards me with their leg to be blocked on top, and then we'll show this on a picture in a second, but having the probe behind their leg, coming in from behind their leg, so reaching over behind their leg and then blocking from above with the needle. The other option is having them prone, but that, for some patients that might be fine, but for others it might be quite difficult or uncomfortable. Again, you're probably going to be able to use the high frequency probe. The chance with bigger legs that you might need the extra, if you're going anything above 4 centimeters ish, you might find you get a better image and it's easier with the curvilinear probe. You probably need the slightly longer needle for this one, so probably worth going with a 100mm needle, again in plane, and you're talking probably a volume of about 20 mils for a normal kind of popliteal block. So this is just a couple of pictures. We haven't got a picture of the supine technique, but this one shows the prone technique, and this one the lateral technique, which is the way I feel kind of most comfortable and the easiest, the best position that I find to do the block. So again, you standing on this side, everything in a straight line, and the screen on this side of the patient. I would start by plonking the probe just straight behind the knee in the popliteal fossa and trying to identify some landmarks. And ideally, you're trying to identify the popliteal artery. The nerve should always be a bit superficial and maybe normally a little bit lateral to the artery as well. So this is just, I plonk the probe on in the popliteal fossa. We've got the popliteal artery, the popliteal vein above it, and then you can see there's definitely some nerve tissue here and some nerve tissue here, it looks like, which become more obvious as you scan up and down. But it looks like the sciatic nerve is already split because we're quite low down, and that'll be the tibial component, and that'll be the common peroneal. So then if you scan up the leg, you'll then eventually find something like this, where the sciatic nerve is 1. You can almost see that they're kind of starting to divide, starting to become 2 there, but generally it's 1 big chunky nerve surrounded by this kind of quite thick fascia around it. Highlighted the nerves there, or the nerve there. And then you've got biceps femoris laterally, and semitendinosus and semimembranosus medially. This is just a video showing this kind of interesting property of ultrasound that can be quite significant when looking at the sciatic nerve, which is called anisotropy. So if you think about the course of the sciatic nerve, in the leg, it starts quite deep up in the kind of gluteal region and ends up fairly superficial down behind the knee. So actually it's not traveling parallel to the skin, it's traveling at quite an angle. Now, if you want to hit with your ultrasound beams, you want to hit the nerve at right angles, so all the beams bounce back to the probe and you pick up a nice crisp image. If you put the probe at right angles to the skin, you're actually going to be at quite an angle to the nerve, so the ultrasound beams are going to be deflected off at an angle and not necessarily come back to the probe. So you can find that you're scanning directly over the nerve, but you don't get a good picture. So this is me just behind the knee. Just start that again. in the same position, but just changing the angle of the probe. And you see you go from a nice crisp nerve, crisp image, suddenly it's all disappeared and you think that you can't see anything. And then change the angle slightly and you come back to this really crisp image of the nerve here. So it can just be worth playing with the angle of your probe to try and optimize your image. There's a video of scanning the nerve. So here, I can convince you that this is the nerve still all as one, just starting to divide, but it's still all one here. And I'm going to scan down the leg and then back up again, just to show the nerve dividing and the two components spreading apart. And then coming back up the leg, and they'll join together again. And then I'm trying to find an optimal place to perform the block. So this is a picture of what I would suggest is a good place to perform the block. So you can see here that you've got the tibial component of the nerve, the common perineal here. So they've split, they're two nerves, but they still looks like they're connected. They're wrapped around by this kind of one sheath that you can maybe even see here in between the nerves. So I think if you could get your needle in that little gap there between the two, you might even get away with one injection and local might spread around both nerves. That would be the ideal. If you block higher up where it's still one nerve, it's such a big thick nerve that it takes a long time for that local to kind of diffuse in and for the block to come on. So ideally blocking them when they've just about separated is going to be more effective and a bit quicker. So again, just to reorientate, you've got the artery there, the vein there, tibial nerve there, and common perineal nerve there, biceps femoris and semitendinosus and membranosus. And then, as I say, if you can squeeze the needle into that little gap between the two, ideally within the sheath that's surrounding the nerves, you might be lucky and get that kind of spread of local. Obviously, it's not always that easy, so you might actually end up doing a few different injections, one maybe underneath the lowest section of the nerve there to kind of lift everything up towards you and make it a bit easier. Maybe an injection above common perineal there, maybe one below the common perineal, maybe one above the tibial here. Essentially trying to do as few needle passes and injections as possible that are going to give you good spread of local around both nerves. This is just a different leg, but showing the same thing. Tibial component here, the common perineal here, and you can kind of see that there's this membrane still in between the two that you could, this sheath that you could hopefully get into with a needle and give you a good block. This is just a little video showing a slightly less than ideal anatomy. I think this is my leg. So if anyone ends up doing a popliteal block on me, then bear this in mind. But you can see that as the nerve splits, this big vessel from the vein just comes off and goes right between the two. I'll just start that again. The vessel comes off and goes right between the two nerves, just where you're kind of thinking of doing the block. So unfortunately, it's not always as easy as that first picture suggested, but you just have to compromise and find a different place. So in this example, I just scan a little bit higher, still trying to find a good position, but giving up, come a little bit higher where the nerves are kind of still just about connected. They're maybe just starting to divide, but you just have to compromise and perform your block there. I'd probably maybe bring the needle in above the nerve to start with and hope that I got spread around, rather than risk bringing the needle down here where I know that vessel is branching off. But it just shows that you have to be a bit flexible and compromise sometimes. Okay, so that's all of them covered. So we've back to the list of the Plan A blocks, and we've covered the femoral, adductor canal and popliteal blocks. We've talked about the Fasciariaca and the lateral cutaneous nerve of the thigh. And in a month or so's time, hopefully we'll have another session on these trunk blocks. So hopefully we'll see you again for those. And then this is an image that just popped up when I was looking for pictures of the setup for the blocks. These two American blokes have set up a club called the Needle Jocks. So hopefully you'll be confident enough to go off and do all these blocks, and you can be as cool as one of these guys one day, perhaps. And if you don't mind just doing another post teaching kind of questionnaire, if you can scan that QR code, that'd be really helpful. It might take a tiny bit longer than the first one. There's a few more questions, but it's still hopefully less than a minute or so. And it'd be really good for us to get some information. Thank you very much, and hopefully see you next time.